So good evening, everyone. I am Dr. Sidak Dhillon, as Dr. Sidak just said. Sorry for the delay. There was a miscommunication in with Geo and all of that. So anyway, I'm going to talk a little about Achilles tendinopathy today and what is the latest evidence-based approach that is out there at the moment. So just a little background, some historical background. So Achilles was a Greek warrior who was dipped in holy water by his mother and said to be impenetrable by swords or arrows. The only part that was vulnerable was his ankle, which she was holding him from. That's why it's called the Achilles ankle or the Achilles heel, actually. So that's where he was shot by an arrow and met his demise later on. So coming to the anatomy of the tendons, basically it is a combination of two muscles that go down and join at the calcaneal tuberosity at the posterior part of the calcaneal tuberosity. So it's the gastrocnemius and the soleus, which are your calf muscles. And so the soleus adds majority of the fibers to the tendon. And it is the thickest and the strongest tendon in the body. And it is said to withstand sheer amount of pressure and load from the entire body during different activities that we do. There is no synovial sheath on over the tendon. It is covered by something known as a paratenon. So this paratenon is basically a continuation of your the perimysium from the muscles, and it joins up with the periosteum of the calcaneum to form something known as a paratenon. And there are two bursae around the Achilles tendon. There is one anterior bursa, which is known as the retrocalcaneal bursa, as you can see in the photo. And there is a posterior bursa, which is known as a subcutaneous calcaneal bursa, or also known as an Achilles bursa. So these bursae, they prevent friction between the bone and the tendon, like when there is movement around the calf muscle. So the blood supply of the Achilles tendon, although tendons don't receive blood supply, so the blood supply of the paratenon and the surrounding structures are from two arteries. There's the posterior tibial artery and the peroneal artery. So as you can see in the picture on the right side, the yellow part of the Achilles tendon, which is the proximal and the distal part, they are supplied by the posterior tibial artery. And the middle part, which is the mid portion, is supplied by the peroneal artery. So this portion is, as compared to the rest of it, has decreased blood supply. And this is considered as the weaker part of the tendon, so to speak. Moving on. So like I said, the Achilles tendon takes sheer amounts of load during different activities. So it is said that it can take up to 8 times the body weight during activities like jumping, and about 12 to 13 times the body weight during activities like sprinting. So it is constantly under superior amounts of load when we are doing some physical activity. So regular exercise will help in increase in the diameter of the tendon due to hypertrophy and other things. So it is a good measure to protect the tendon against injury to be regularly exercising. Similarly, inactivity and decrease in activity or as compared to earlier will lead to rapid atrophy of the tendon, making it more susceptible to injuries. Along with this, with age, the cell density and the collagen fiber density will decrease. So that is why they say that older athletes or older people who are active are more susceptible to injury as compared to younger people. So a clinical picture of basically any kind of Achilles pathology. So in a case of acute tendon rupture, it occurs most commonly in older middle-aged people, like 30 to 50-year-olds, and it is more common in males as compared to females at a ratio of about 10 is to 1. So it is said that the typical patient of an Achilles tendon rupture is a 40-year-old male. That is the general consensus. So tendinopathy occurs when there is increased training volumes or increased training intensity that the person or the athlete is not used to as compared to before. So it is of two types. There is midportional tendinopathy and then there is insertional tendinopathy. So midportion tendinopathy is also known as non-insertional tendinopathy. It is the more common of the two. Um, and it has a better prognosis as compared to insertional tendinopathy, because insertional tendinopathy has a worse prognosis as compared to this. Also, mid-portion tendinopathy usually occurs in more in older people, and insertional tendinopathy will occur in people who are more active and who have a higher level of activity as compared to the other people. So the injuries, even an acute rupture or mid-portional tendinopathy, usually occur in the weak part of the Achilles tendon, which is about 2 to 6 centimeters above the insertion point. This is, like I said earlier, because the vascular supply over here is not adequate as compared to the rest of the tendon. So that's why it is weak and the healing process is reduced. So tendinopathy, like I said, is usually caused because of overuse or sudden increase in intensity or sudden increase in activity levels, reduced amount of stress reduced amount of rest, sorry, between two bouts of activity. So all of those will lead to tendinopathy. So the symptoms will usually be gradual in onset, and the person can actually feel them coming on gradually over a few days or few months. The most common symptom that you will get someone who comes to you with Achilles tendinopathy will be a complaint of pain and stiffness in the morning. This will be the first thing they feel in the morning when they wake up. Secondly, this pain can be reduced by walking around and by applying heat. That is usually when it reduces. This pain also usually occurs after activities, after basically exercise or running or cycling, something like that. The pain will suddenly increase again, but it will gradually decrease as the body cools down. Coming to tears, so partial tears, in case of partial tears, there will be a sudden onset of pain, and this usually happens during activity, and they are less common than tendinopathy, but the pain is a lot more disabling and a lot more severe. In cases of complete tear, there is a sudden pain and severe pain, especially during exercise or a bout of activity. The athlete or the patient usually comes to you and says that they heard a pop, and a very typical of history is that they usually say that it felt like someone kicked them in the back of the ankle. So that is a telltale sign of an Achilles rupture. So some common causes of pain in the Achilles tendon region, in the Achilles region, sorry. So the common causes are mid-portion Achilles tendinopathy. So this can be, so you can include partial tears, tendinosis, and paratendinitis in this. And Achilles tendon rupture, then posterior impingement syndrome is also a very common cause. So this usually occurs when in cases of continuous and prolonged plantar flexion. So, for example, in a ballerina, it is very common. Then there is insertional Achilles tendinopathy, and this is usually accompanied by a retrocalcaneal bursitis or a Haglund's disease. It is very rare to see one of these three occur separately or on their own. Two of the three are at least present at a time, most commonly. Then there is Sever's disease, which is basically apophysitis of the calcaneus, usually seen in adolescent children. So these are some of the common causes of pain that can be seen in that region. Then some less common causes are your subcutaneous bursitis or Achilles bursitis. And an accessory soleus muscle usually ends up causing pain and stiffness in the region. Referred pain from any part of the kinetic chain will cause pain, can cause pain in this region. And then tendinopathy due to inflammatory arthropathies like inflammatory arthritis or septic arthritis or rheumatoid arthritis. Any of these, so we need to, so this is basically the differential diagnosis that can be, and we need to rule out all of these before getting to a proper diagnosis. So this is just an image that shows the common areas of tendinitis and your Achilles tendon rupture, and then tendinosis, which is micro tears in the tendon. Coming to the tendinopathies, like I said, there are two types. There is insertional, and then there is mid-portional tendinopathy. So these are very, very common in, especially in sports people. So they say about 9% of recreational sports people have these injuries of one form of the tendinopathy, either insertional or mid-portional, and about 5% of all the athletic careers are usually ended due to an injury with the Achilles tendon. So the predisposing factors are of any of the tendinopathy can be two types, or even actually of can be of two types. So there is extrinsic factors, which include poor surface conditions like running on hard surfaces or running on an inclined surface for too long without proper training, and poor shoe wear or poor footwear, not wearing improper shoes, wearing hard soled shoes, something like that. And then training errors, similarly, like what I said earlier, there is less gap between two training sessions, no adequate rest, and when you're thinking about sudden increase in your training load and all of that comes under training error. And then overuse injuries. So overuse is the most common cause of Achilles tendinopathy, because, like I will not give time for the basic factors are most.
Is my net?
Sorry. Hear me?
Sidak, I don't know. Is it my net? Just 1 second.
Can you hear me? Hear you.
Yeah, I think my. Can everybody else hear? If you can hear Sidak properly, can you just put in a message? Because I feel that. Yeah. Now it's come
I can
back.
hear you.
Yeah. Now it's come back. It's come back. Now you continue.
Okay. So extrinsic factors I just discussed. So extrinsic factors. Now coming to intrinsic factors, which are older individuals being more susceptible to this injury, and postural problems like pes cavus, pes planus, or any other biomechanical problems. Then your decreased strength, muscular imbalance, decreased flexibility of your calf muscles. All of these are predisposing factors. And so intrinsic and extrinsic factors will presence of these will lead to repetitive trauma, which is continuous trauma on the Achilles tendon, which will then lead to microscopic tears, microscopic injury. And because of the gradual onset of the symptoms, the person doesn't realize and keeps training. There is not enough rest, so then there is adequate healing of the tendon, which then leads to either tendonitis or a complete rupture. So clinical features and history. So clinical features, history is one of the most important thing that allows us to diagnose an Achilles tendon pathology, because the way the person gives a history, we can see what it is. We can straight away rule out other things. So the depending on the type of it can be sudden or it can be incident. And where again, it depends on the area of tendinopathy is. It could in the and duration again could be insidious in onset, could happen all of a sudden, or it could be gradual in onset, which means that it could be insidious or it could be sudden. So it could take from days or to months, depending on the type of injury. Disability also may be minimal, moderate, or severe. So swelling is almost always present. Crepitus may or may not be present, depending on the area of the tendinopathy. And the tenderness is usually pinpoint, where the area of tendinopathy, and usually a couple of centimeters above or below the area is also tender to touch. So coming to the clinical assessment, so palpation is the most important thing you can do when you're with a patient. So this test is known as the Royal London Hospital test. It is basically the palpation of the area of maximum tenderness. Uh, Once you identify the area, you ask the patient to dorsiflex completely. After dorsiflexion, you palpate the same area and you can see that the pain is reduced. That is a clear sign of a tendinopathy when the pain is reduced. I'll just show you this video. So we identify the area. Then we can ask the patient to completely dorsiflex. Then we identify the area again, and usually the pain is decreased at this point. The next clinical assessment, something known as the arc sign. So similarly, in the arc sign, we identify the area where there's swelling and the maximal tenderness. Then we ask the patient to actively dorsiflex and plantarflex. And in cases of tendinopathy, the area of swelling will usually move proximally and distally along with the active ROM. So in cases of the tendinopathy, the swelling, the thickness in the tendon will move proximally and distally. Then, so basically, like I said, history and clinical examination are usually enough to diagnose the case, but we have to confirm the diagnosis. So for that, some radiological tests are done. Firstly, X-rays. So X-ray is usually done to rule out any bony abnormality like your Haglunds lesion. So like you can see in the X-ray, the Haglunds region is present on the superior part of the calcaneus, the posterior superior part. So this usually will irritate the tendon by rubbing against it again and again. There's another calcaneal spur present at the bottom, but that will only play a part when it comes to plantar fasciitis. So that's why we do the X-rays. And even we can also see some calcification in the tendon if it is present at all intratendinously. Secondly, ultrasound. So ultrasound is really good because it gives us a dynamic view of the tendon. So all the movements can be seen. Normally we can see a thickened tendon in areas of tenderness as compared to the tendon on the other side. And a color Doppler can be used to see neovascularizations. So neovascularization occurs when there are micro tears in the tendon. The tendon tries to heal itself by neovascularization, but so these neovascularizations are what cause the pain in a patient. These can be seen on a color Doppler, so that will give us an idea about the micro tears. Then your MRI is the best modality to see any signal changes, any tendinopathies, mid-substance or insertional. This is a picture of an insertional tendinopathy. You can see at the insertion point of the Achilles tendon, there is a hyperintensity, which is usually a sign of a tendinopathy. Similarly, you can see it in the mid-substance. So now, since there are two types of tendinopathies, I'll talk about mid-portion first. So it is more common one. It's better among athletes. Even athletes show up with these injuries a lot.
Sidak, can you repeat that? I think.
So, can you hear me?
Yeah, your net is slow, Sidak. Unfortunately. So can you just repeat that thing?
Is the first. But can you hear me now?
Yeah. Continue. You can start again. Right.
So mid-portional tendinopathy. Yeah. So mid-portional tendinopathy is more common than your insertional tendinopathy, and it is very common in athletes and.
I think Sidak has gone out of this thing itself. What happened suddenly? Just 1 second.
You muted me, sir.
No, I'm not muted. I can hear you. What happened suddenly to get cut?
I don't know.
Okay, just share it again. Just share your this thing. And
Okay, can you hear me now?
yeah, I can hear you.
Okay, sorry. I don't know why my internet is acting weird, but okay. Anyway, so should I continue?
No, share your screen. We can't see your screen. That has gone off.
Oh, sorry about that.
Yeah, so just play from there and then.
Yeah.
Yeah. Now continue.
Okay. Okay. So, like I was saying, the most common area of the tendon that is affected is about 2 to 6 centimeters above the insertional site. Again, because of the poor vascularity. So the treatment usually is always started with conservative treatment, but surgery might be required in about 25% of the cases that do not respond well to conservative management. So first, the early management. Early management is about 1 to 2 weeks. So this starts with the activity modification. So we don't need to stop all activities of the athlete. We just have to limit the jumping and sprinting activities, which put most of the load on the Achilles tendon. Other activities like your calf stretches and all of that still need to continue. And cycling is not a bad thing in this case, but jumping and running have to be limited. So NSAIDs are usually given in the initial management, but these only have an analgesic effect. Orthosis can be given, which reduce the peak forces which distribute the peak forces on the tendon, like your pneumatic boots and all of that can be given. Then we come to sports tapes. So sports tapes are very helpful in the initial management because they help to offload the tendon, and the person can actually go and do some supportive exercises in that case without too much load coming on the tendon. The ultrasound therapy and laser therapy are also helpful for symptomatic management. So from week 2 to 5, we start with the main exercise protocols. So the Alfredson's heel drop protocol, even though it is an old protocol, it is still used widely by most of the people that even I know personally. Along with these, so there is nitric oxide donor therapy, there is sclerosing injections, extracorporeal shockwave therapy. So all these therapies are used in adjuvants with your heel drop exercises. So your heel drop exercises are the mainstay of the therapy, and the others are what we use to in addition to that. So an Alfredson's painful heel drop protocol is basically an eccentric protocol. We use an eccentric training protocol because it reduces the load on the tendon, whereas it provides basically puts the calf muscles under a lot of stress. So it's good for strengthening approach. But again, there is less stress on the tendons. Along with this, when the tendon is stretched, the neovascularizations and the adhesions are usually broken in this case. So that's why an eccentric protocol is what everyone usually follows, or is what the data says at least. So there are three components to this. First, the patient will usually come to you with worsened pain. This is a good thing because it is a sign of recovery as the adhesions are breaking and your neovascularization is breaking. That is when the pain might increase initially. So two types of heel drops are incorporated. One is for the gastrocnemius, one is for the soleus. So for the gastrocnemius, it is done in full extension of the knee. For the soleus, it is done in about 45 degrees flexion of the knee. The basic protocol states that 180 heel drops need to be prescribed per day. Earlier, it used to be less than this, but then people have found a balance in this protocol with 180 heel drops. So the exercises are done twice a day, once in the morning and once in the evening. So about 3 sets of heel drops with full extended knees are done, about 15 each. And then similarly 3 sets with 45 degrees of flexion. That is 90 heel drops in the morning and 90 heel drops in the evening, which comes to a total of 180. So the training program is usually 6 to 12 weeks, and the patient usually starts feeling a difference within the first 4 weeks. About 90% of the patients show successful results and positive results. And MRIs and ultrasounds can be used to compare with the normal tendon, and you can see that the tendon usually slowly starts returning to its normal appearance and thickness. So this is the first type of heel drop with a fully extended knee. So as you can see, the normal knee is bent and heel drop is done, but you have to make sure that the patient knows that only eccentric loading is required. So when they go down, the Achilles tendon is eccentrically loaded, and while coming up, you use the help of your normal ankle to do the same, to do the consent, so that to avoid concentric loading. So this is the one for your gastrocnemius with the completely extended knee. Secondly, with the flexion of 45 degrees, you do the same thing for your soleus muscle. But like I said, it is very important to use your normal ankle to get back into the upper position. Along with this, so we need to use some kind of modalities that will help with your symptomatic relief. For example, your nitric acid, nitric oxide donor therapy. So we use patches of glyceryl trinitrate. These patches are basically locally applied, and they help in reduction of pain. So you get these patches in two sizes, usually 0.5 mgs, which you can cut into quarters, and 0.2 mgs, which you can cut into halves. And they are usually applied at the area of maximum pain. So the patch needs to be renewed every day. And a pilot study was done in which one group was given a placebo patch and the other group was given a GTN patch for 6 months. So in the GTN group, it was seen that the activity pain was reduced. So it was seen that the pain after activity was significantly reduced, and it had a better outcome overall after 6 months. Sclerosing injections. So basically, sclerosing injections are ultrasound guided injections. Most commonly for this, for Achilles tendon, they use polidocanol, which helps in sclerosing the areas of the neovascularizations, and it is given anterior to the tendon. So these injections are given at intervals of about 2 to 8 weeks, depending on the patient and how the symptoms are. So another study was done in which there was marked reduction of pain, and there was better activity seen in a group that was given this injection as compared to a group that was given a placebo injection after 6 months. The same group was seen that at a 2-year follow-up, in which there was less recurrence of symptoms as compared to the placebo group. So the ultrasound can be done later to see that there is a reduced thickness of the tendon as compared to the earlier vessels. This occurs because so when there is sclerosis of the newly formed vessels, it reduces the thickness of the tendon, and even the vessel numbers are usually decreased. So the rehabilitation after this injection includes a rest of about 1 to 3 days, and then gradually the activity can be started again. Jumping and running, sprinting are usually avoided during the first 2 weeks, but after first 2 weeks they can all be started again under supervision, obviously, of the coaches or the trainers or even the sports physicians or physiotherapists. So research has shown beneficial role of sclerosing injections, especially in those patients who do not improve with eccentric exercises. Extracorporeal shockwave therapy also, there have been some randomized controlled trials done for Achilles pathologies, but these are, so the results have not shown a very, either a positive or a negative outcome, but the same shockwave therapy has been used for other tendon injuries like tennis elbow and all, in which there has been a very positive result. So a lot of people use this as a modality, which basically it helps in decreasing your post-exercise soreness and It is beneficial when it is used along with your exercise protocols. Corticosteroid injections. Corticosteroid injections into the tendon should always be avoided. They're contraindicated because they lead to further worsening of the pathology, and they also lead to tendon rupture. So this in this area, the corticosteroid injection is usually given in the paratenon, and it should be given under ultrasound guidance or by someone who is very confident in his work. So studies usually show that short-term improvement is seen after in patients in walking, and even the tendon diameter is reduced due to the anti-inflammatory effect. So this injection should also be considered as an adjuvant to the eccentric exercise protocol. Then PRP injections, the whole PRP fad is growing very fast these days, and a lot of people are using them in Achilles tendon pathologies. So there are growth factors that are present in the PRP which will facilitate healing, and they will promote healing. So studies have shown that there is an increased expression of the collagen type 1 and 3 and endothelial growth factor, and this helps promote healing and proliferation of cells. So then deep friction massage is another thing that is another modality that is used by lots of people. So this leads to mobilizing. This is basically done to mobilize the tendon. So the mobilization will lead to friction, which increases the protein output of the tendon cells, which will again help in healing, and it also increases the tissue elasticity when done along with your calf stretches and all of that. So this will basically reduce your muscle stiffness, and it will reduce strain on your muscle tendon unit. Additional management includes your analgesics, cryotherapy, night splints and braces can be used, in which the tendon is kept in a the ankle is kept in a dorsiflexed position, so to keep a constant stretch on the tendon. And then your if there are any biomechanical errors in the limb, then that should always be modified using different orthosis or other things. So this is your algorithm for management. So if for midportional tendinopathy, when a patient presents with pain, first we have to exclude a rupture or any other. We have to exclude any other pathology. So after that, after the first week of basic management, we begin the Alfredson's heel drop exercise program for 6 to 12 weeks. So like I said, within 4 weeks, you will start seeing a positive response. If yes, then you continue the exercises as a maintenance form. If no, then you can do the following things. So you have to continue the exercise, but you evaluate the kinetic chain and you modify the load. You can increase the load, and you can think about using your GTN patches for about 6 to 12 weeks. You can continue the exercise, add some biomechanical assessments to see if there is any issue, and your deep tissue massage, electrotherapy, and your GTN patches can be involved. Otherwise, you can add a pain relieving adjuvant like analgesics, or even your extracorporeal shockwave therapy, corticosteroid injections, and you can try sclerosing treatments along with your exercises. And lastly, if none of this works, then surgery is usually thought about. So at least 4 months of conservative treatment needs to be done to move on to surgery. So surgically, percutaneous tenotomies are done under ultrasound guidance. So degenerative tissues are resected, and low-grade trauma is induced onto the tendon to promote healing. And open release of adhesions can also be done. If there is 50% of the tendon that has been debrided, then you have to consider reconstruction. But less than 50% tendon, up to 50% of the tendon can be debrided without thinking about reconstruction.
Can I ask you a question over here?
Yes, sir, please.
Yeah, the only thing nowadays I'm using the PRP therapy for this thing, but practically I have seen a difficulty while injecting a PRP in the Achilles tendonitis. It's not
Yes, sir.
simple, even ultrasound guided. It's not simple. If you have seen
Not at all. Yes, sir.
so if you can see some tiered fiber over there, if you can approach guidedly and you are seeing your needle exactly over there on the spot, but it's not possible to inject the platelet plasma over there. It's very tight.
Yes, sir. So that's why they usually try to inject it between the tendon and the paratenon, or usually in areas of micro tears. It is like you said, it is not very easy to visualize either. So the
Even with the hockey stick probe, if you
yes,
can
sir.
use over there in ultrasound guidedness, even it's not possible if you can find out the strains where the tear is exactly and the fibers where they exactly tear off. Exactly if your needle, if you can see the mouth of the needle is over there exactly, still it's
Yes,
not
sir.
possible to inject.
Because of the tendon microstructure being very hard, so you're right.
Exactly,
So that
exactly.
so in that's why they usually say that you have to inject around the tendon and as much as you can. Just one
Around
or
the
two.
tendon can help, yeah. Around the tendon can help if it's externally, but if the deep fibers are teared up, it's quite impossible to give the result in that case.
So are you talking about intrasubstance?
Exactly.
So intrasubstance, then they usually don't use PRP because, like you were saying, it is very hard to get to. So in an intrasubstance tear, we usually try to just maintain it conservatively, and then we usually PRP is, like I said, very new to all of this. So people are still trying
No,
to go about it.
very frankly speaking, in case of
Yes, sir.
ACL, PCL, MCL, LCL, and the meniscal tear, grade 3 even, I'm giving very good results over here because I can
So,
approach there, and it's not possible for me to see the ACL exactly, but if you can spread around in the knee through the
yes, sir.
suprapatellar abscess, if you can spread around the whole PRP with a good thick PRP in the knee, you'll get a good result in the ACL grade 2, grade 3 even.
Yes, sir.
But in case of only Achilles tendonitis, I got it twice. I got failure just because it's not possible. A lot of strength it is required practically. In a one hand you are holding the probe, the hockey
Yes,
stick
sir.
is very small, and on
Yes.
another hand you are just pressing it. It's not possible to inject it. It requires a lot of power, a positive energy you have to send and force. You can. It's a torque kind of a thing.
So I agree with you, sir. But that's why I mean, I don't know how to answer your question because that is why they don't usually do. I mean, what I have read is that they aren't usually doing PRP for intra-substance because if the tear is within the substance and the tendon is there is no tendon injury or no tendon pathology extra like on the outside, then the PRP will anyway not be going into the tendon.
No, I'm just sharing my personal experience with you
Yes, sir.
because I've done it. I've done it twice. Even in a one case, I got failure because the calcaneum area was very prominent on that particular patient, and it was just like a spur kind of a thing. It's coming out as we can see
Yes,
in
sir.
downward spur. It was on exactly on the where the insertion of this Achilles is there. So
Okay, sir.
to approach that area, it was so deep. So practically, whosoever is listening, I just wanted to share my personal experience. It's not possible to to send the PRP exactly up to that spot so that patient or the athlete can get healed up with the PRP. Practically, it's not possible.
Yes, sir.
So please carry on. I'm enjoying. Please carry on.
Thank you, sir.
Yeah.
So now coming to the insertional Achilles tendinopathy, like I said earlier, so these three things, retrocalcaneal bursitis, insertional tendinopathy, and Haglund's disease very commonly occur together. Very rarely will you see only one of these happening. Normally, at least two out of the three are present. So since they are related, we can discuss them together. So the tendon insertion site, the fibrocartilaginous walls of the bursa and the calcaneum itself, they form something known as an enthesis organ. So enthesis is basically the connective tissue between the bone and the ligament. So at this site, the tendon, bursa, and bone are very intimately related. So any change either in the bursa or the tendon will lead to any bony prominence will lead to an irritation of the bursa or the tendon. Similarly, when the ankle is dorsiflexed, the there is a lot of strain on the tendon, on the posterior aspect of the tendon. And then the Haglund's disease is basically the presence of any of this of these issues when there is a presence of a Haglund deformity, which is a posterior calcaneal spur. This Haglund's deformity will irritate either the bursa or the tendon, leading to tendinopathy and one of the three. Two of the three. So this is an image showing the anthesis organ. Like as you can see, the bursa, the Achilles tendon, and the calcaneus are very closely organized. So an inflammation or an irritation of one will lead to a pathology in the other as well. So this is a clinical picture of a calcaneal spur or a Haglund's deformity. You can see the X-ray showing the Haglund's deformity, and then even the picture of the posterior part of the foot of the individual, which shows a bony prominence. So the clinical assessment again will be the evaluation of the tendon, bursa, and the calcaneum have to be done separately because they are all related very closely. So predisposing factors to insertional tendinopathy will be biomechanical abnormalities, any hindfoot eversion, any joint stiffness due to any joint stiffness, or any soft tissue tightening like calf tightening or something like that, which will basically restrict your movements. Then radiologically, ultrasound and the MRI will show the bursa and the tendon very well, whereas the X-ray will show the calcaneal spur or any other deformities in the bone. So in the conservative management, the anthesis organ has to be considered as a unit. Isolated treatment usually is not successful. In this case, the Alfredson's heel drop protocol, along with the sclerosing injection, have shown the best outcomes out of all the other modalities. A heel lift in both the heels can also help to unload the tendon, and it has shown promising outcomes. Again, taping and bracing will help with symptomatic relief and will help the patient do the exercise protocols better. And for retrocalcaneal bursas, non-steroidal anti-inflammatory drugs can be used, or even the intrabursal corticosteroid injections are very, very helpful. So surgical management is straight to the problematic region. So there is removal of degenerative tissue along with associated calcification. If there is an inflamed bursa, then excision of the bursa is done. Resection of the Haglund's deformity is very important. Otherwise, it will keep reoccurring, the issue. And after the degeneration, after the degenerative tissue is removed, the reinsertion of the Achilles tendon is very important. Usually suture anchors are used in this case, or if more than 50% is taken off, is resected, then we have to think about graft or reconstruction. So, and calcaneoplasty and excision of the bursa can also be done endoscopically, but your degenerative tendon needs to be done through an open procedure. So briefly about Achilles tendon rupture. So an untreated tendonitis or a tendinopathy very commonly can lead to an Achilles rupture. So this usually occurs in older athletes from 30 years and above. So like I said earlier, a typical patient of an Achilles tendon rupture is a 40-year-old male, because males are 10 times more susceptible as compared to females. Clinical presentation, the patient usually comes to you and says that he felt like he got kicked in the back of the ankle, and there's a sudden snap or a pop that is usually heard in this or felt in this case, and the pain is very, very sudden and immediate, and there is sudden loss of function of the athlete as well. So there is usually an obvious limp, but this limp can be compensated by the accessory muscles. clinical examination usually shows lots of swelling in the area of rupture, and you make the patient lie in a prone position. Both the ankles are fully relaxed, and the affected foot usually hangs straight down, whereas the normal ankle will be seen in slight plantar flexion. So usually there is a palpable gap in the most common site of a tendon rupture is 2 to 6 centimeters above the insertion because of the decreased vascularity. So usually there is a palpable gap in this area, and in some severe cases the gap can even be visualized on examination. So the Thompson test is one of the most commonest tests done in this case. Basically, it is also known as a calf squeeze test. So like I said earlier, in a prone position, when the ankle is relaxed, the foot usually lies at a slight plantar flexion. In this case, it will be lying more of a neutral position than a plantar flexion. As you can see, the left ankle in this case is the one which is injured. So when a calf squeeze is given, there is no movement at the ankle. As compared to the other side, when there is a calf squeeze given, there is a slight plantar flexion of the foot. So this is a very sensitive positive test for the same. Another test known as the Matleys test. In this, patient is in prone position, knees are flexed to 90 degrees, and so normally this is actually a normal patient. So normally the foot will be in plantar flexion, like you can see right now, slight plantar flexion. But in cases of a ruptured Achilles tendon, the foot will be in more of a fallen down or a drooping position like this as compared to the other side. So these tests usually are more than enough to tell us if there is an Achilles tendon rupture. Most probably, if the patient gives you the history that I just spoke about, you can diagnose that he has an Achilles tendon rupture. But an MRI will show you is basically the gold standard in this. It will show you a straight gap in the tendon, which will just help to make your diagnosis more concrete. So treatment for this, mostly I personally would suggest if it is a younger athlete, then we go for a conservative type of treatment. But if it is an older athlete, as early as possible, surgery should be advised. So an open tendon repair is done. So it is usually, it poses a lower risk as compared to your conservative treatment in older athletes at least. And the normal complications like infection and adhesions and skin sensitivity can be seen. So post-operatively, early mobilization is usually preferred as compared to immobilization in the cast. Earlier, they used to do a post-operative cast immobilization for 8 weeks, but now they have started doing a early mobilization for 4 weeks. They usually put the patient in a functional brace. This has shown a better outcome as compared to the immobilization protocol they were using earlier. So in the conservative management, in older patients who are not athletes but regular patients, you can go for a conservative management because they have a low level of activity. So the cast immobilization is usually done for 4 weeks. This cast is placed in a maximum plantar flexion, but now you can also get braces for the same. So there is a maximum plantar flexion for the first 4 weeks, and in the next 4 weeks, the amount of plantar flexion is gradually reduced. So a total immobilization is usually done for about 8 weeks, and after all of this, we can start with the exercise protocols that we did in your Achilles tendinopathy. So after this, we can follow the same algorithm as we did earlier. So that's about it.